All right. Welcome everyone to the next session of Clinical Learning series. Today we are starting with the dermatology series of lectures that we are planning to have. The first of the sessions in this series is approach to skin infections. Approach to skin diseases. This presentation is being given by Dr. Ancia Dsouza. She is MBBS batch of 2016 from St. John's Medical College, Bangalore. Currently, she is working as a resident medical officer in Goreteam Hospital, Udupi district of Karnataka. Welcome, Dr. Ancia, for this session. Her advisor is Dr. Mihika. Mihika, as we all know, is MD Dermatology from St. John's Medical College. She is UG alumni from the same college and did her post-graduation from the same institute. Currently, she is a consultant in dermatology in Pune. She has experience in working at rural setup at Forad Mobile Medical Unit in Tiruvallur, Tamil Nadu. Already Dr. Mihika has shared a screen. So now I invite Dr. Ancia to start her presentation. Dr. Ancia will get around 30 to 40 minutes. I will give you a quick update on the time after 30 minutes. Please start your session. Thank you so much.
Thank you so much, sir. Am I audible?
Yeah.
Okay. Today I'll be talking about approach to skin diseases and this common skin infections, which are mainly encountered in the born centers and the rural population. Next slide. Okay, so an overview of today's lecture. First, we'll talk about history taking, then morphology of different skin lesions, that is primary skin lesions and secondary, then distribution of different skin lesions in different conditions, then red flags for referral. There are a few conditions which need referral and should be managed only by a dermatologist. So what are those conditions? And a few common bacterial infections, viral infections, fungal infections, then infestations and insect bites, and what are the differentiating factors between a viral and a drug rash, which is very common in all rural born centers and all hospitals. We encounter this drug rash, so it's very important to differentiate. So regarding history, sorry. So first, age is very important. So why is age important? Because a few conditions like, so based on age group, so impetigo is mostly seen in children. So bullous pemphigoid is seen in elderly population, like 70, 80-year-olds. Then conditions like psoriasis, they typically have two peaks, one in teenage and one in old age. Then occupational history is very important because sometimes eczemas, maybe a patients come with eczema and we should find out if there's any chemical which is triggering it, like sometimes exposure to nickel or anything will cause eczema. And sometimes patients come with eczema in mostly dermatitis in the exposed areas like face and hands. So we should so occupational history is important because we should know if the patient is exposed to a lot of sunlight or dust and pollens, which is causing this eczema. Then in history, duration of symptoms is important because usually acute means infection. Any autoimmune etiology or autoimmune pathology means they'll have chronic symptoms. Then always it's better to ask associated symptoms like itching. So usually eczema and different kinds of dermatitis are very itchy. Then complaints like pain, conditions like herpes zoster are very painful. Then bleeding, we see bleeding in conditions like pyogenic granuloma, sometimes so sorry, psoriasis. They'll have when the scales are when we scrape the scales, they might be bleeding. Then systemic symptoms like fever, joint pain, oral ulcers, and photosensitivity. So this is when these symptoms are there, it points out towards a connective tissue disorder. So always we have to ask these symptoms, and other history of any other treatment, like any allopathic treatment or alternative medicine. So this is because there are few drugs which can trigger a few dermatological conditions. Drugs like sulfonylureas, which are mostly used in diabetics, are they are known to trigger lichen planus, and antibiotics are known to trigger vasculitis. So this is about the history. Next, coming to the morphology of skin lesion. So this is a picture of primary skin lesions which are present. So first one is macule. So macule and patch, there's only difference in the size. So it is neither raised nor depressed, it's just change in color. It can be either hypopigmented, hyperpigmented, or depigmented. So if it's less than 1 centimeter, it is a macule, and more than 1 centimeter, it's a patch. Example for macule will be cafe au lait spots, which you see in neurofibromatosis. And for patch, vitiligo, usually there's sorry, depigmented patch. And then there is vesicle and bulla. So these are fluid-filled lesions. Fluid-filled lesions. So if it's less than 1 centimeter, it's called vesicle. Mostly seen, common condition seen as either chickenpox or herpes zoster. And bulla, it is more than fluid-filled lesions, which is more than 1 centimeter. So this you can see in conditions like bullous impetigo, then pemphigus vulgaris, bullous pemphigoid. Then there's something called papule and plaque. So papule, it is a circumscribed, solid, elevated lesion. So this papule, the classical condition where you see papule is lichen planus. Then plaque, usually you see it in psoriasis. It's same. The size is more than 1 centimeter. And nodule is something which is like usually better felt than seen, because there is it is a papule, but there is a depth of more than 0.5 centimeter is a nodule. Then there are a few specific lesions like wheals. You see wheals in urticaria. There are some next slide, please. Okay. So based on color and secondary change, there's hypopigmented, and depigmented patches. Depigmented lesions. So hypopigmented is usually seen in leprosy. Hyperpigmented, we can conditions like tinea lesions are hyperpigmented. Depigmented, it is vitiligo. Then skin colored lesions. Skin colored lesions mostly seen in molluscum contagiosum. So it's classical skin colored umbilicated lesions which is seen. Scaling is exfoliation of the skin. So this you can see this in psoriasis, classical silvery white scales in psoriasis, or in case of pityriasis rosea, you can see colored scales. Even tinea presents with mild scaling. Crusting is it's like the dried exudate. It depends on what is the content. It could be either blood, serum, or pus. So based on that, there's yellow color, red color crust. And excoriation is basically like seen in insect bites, and it's basically papules which after itching and scratching, they become excoriated, mostly seen in scabies and insect bites. Next, coming to based on the distribution, see, this is classical dermatomal presentation, which is seen in herpes zoster. Next slide. This is linear presentation in case of morphia. So, next slide. This is blastoid. That is, it presents along the lines of embryonic development. It is seen in epidermal nevus. Flexural atopic dermatitis usually involves the flexures, whereas psoriasis usually they present on the extensors. It's usually because one, extensors are dry, and second, because they're more exposed to trauma. So the keratinorization happens, and psoriasis is mostly seen on the extensor surface. Then exposed area, when patient comes with dermatitis on the exposed areas, it's mostly phytophotodermatitis. That is, if there is dermatitis like the allergy to the sunlight and like to the pollen and to the plant. So in India, mostly it is Parthenium plant. So, and the next picture is papular urticaria. In like colloquial term, we call it like insect bite reaction. So this is but mostly seen in children who are like less than 6 years of age. So next is red flags on referral to a dermatologist. One is erythroderma, more than 90% body surface area. So this body surface area is calculated based on rule of nine, how we calculate in burns patient. So any patient having erythroderma more than 90% needs a referral. Then bullous lesions. So bullous lesions are usually, so it's either pemphigus vulgaris or pemphigus or bullous pemphigoid needing investigation. So you need to refer, or it could be bullous impetigo or Stevens-Johnson syndrome, so needs referral. Pustules in a patient with psoriasis mainly indicates it's pustular psoriasis. Patient will be very sick and very toxic, so needs a referral. Any vitally unstable patient like having tachycardia, hypotension, usually in case of Stevens-Johnson syndrome or any bacterial infection, the like patient needs a referral to a dermatologist. And skin tenderness, again, it is seen in Stevens-Johnson syndrome and TENS. So these conditions, they need a referral. Like, please don't try to manage it in your small burn center. Please refer to a full-fledged hospital. Next. This is something everybody should know. Like, these are a few combination drugs, combination creams available, which are not recommended. Like, they're not indicated. There's not a single condition where these are indicated. So this is actually a combination of fungal and steroid, or antibiotic and a steroid. So it's so these should be avoided at all costs. So any tinea treated, it's just going to be like a steroid treated tinea, and going to be all it's going to cause is drug resistance. So better avoid those. You have to stop using those creams. Next, coming to viral infections, there's molluscum contagiosum, first one. So you can see skin-colored umbilicated lesions. So most commonly it's seen in the pediatric age group. So whenever it presents in adults, we have to rule out HIV, because in adults it's mostly sexually transmitted. So how do we treat this? So usually in medical colleges and all, they do curettage and remove it. So what we can do is we can actually like take a needle and curate the contents out. If not, if we don't have that facility, then give Vaseline. You can apply Vaseline at the base and take and give 10% KOH to the patient and ask them to apply every day at the center for around 2 weeks. Till the lesions are crusted. Once they are crusted, then like they just fall off. So what are the red flags in molluscum? If they are giant, if they are extensive molluscum, if they are giant molluscum, that is if it is more than 1 centimeter, and agemone, that is if the lesions are one above the other. They are like, so this need, when these are there, we have to rule out HIV. Next slide. Okay, this is herpes simplex. So this, so usually clinically, we identify, because it's like vesicles on an erythematous base, grouped vesicles on an erythematous base. So the one test which we can do is Zank. Zank we do, and we see multinucleated giant cells. And incubation period for this is 3 to 7 days. Next slide. Okay, so the clinical features, it presents, next slide. It's a grouped vesicles on erythematous base. It starts followed by erosions and then healing. So primary attack usually is most severe. It's very severe. So they'll have all toxic symptoms like fever, severe lymphadenopathy, and malaise, fever. Recurrences are comparatively mild with shortened clinical course. So every time like the patient has herpes, there is a predisposing factor. So either it's a trauma or stress, like premenstrual, high-grade fever, any infections, surgery. And nowadays, dermatological procedures without proper care can also trigger herpes. So we should ask for all these predisposing factors and treat. So the treatment for this, if it's a primary or the first episode, acyclovir 400 mg thrice a day for 7 to 10 days. If it's recurrent, for the second recurrent episode, you treat the same way. So the suppressive treatment is given in case of recurrent herpes infections. So when do you call it as recurrent herpes is either more than 3 episodes in 6 months or more than 6 episodes in a year. So this time you give 400 mg BD for 6 months to 1 year. Next is varicella or chickenpox. Okay, so this is classical vesicles. You call it as dewdrop on rose petal appearance. Clinically, we can. So what is the likelihood on getting this disease on exposure? So likelihood on getting is 60 to 100% whenever you're exposed to chickenpox. So when do you get it? The incubation period for this is around 2 weeks. And how will the disease start? It will start with constitutional symptoms like fever, malaise, which will they'll develop vesicular lesions, then crusting, and then scars. So how do you diagnose varicella? Clinically, as I said, dewdrop on rose petal appearance. And there is lesions at different stages of development. So there is macules, papules, pustules, vesicles, crusting, and after crusting, it stops. And the side lab procedure, you can do a Zang smear if you have it in your center, and you can see multinucleated giant cells. So this, if the patient is 14 weeks pregnant, is there a risk to the baby if she gets chickenpox? There's 2% risk of fetal anomaly in less than 20 weeks pregnant. So what can she do? Zoster immunoglobulin. So complications of varicella, secondary infection, because in rural areas, usually they tend to apply cow dung and neem and a lot of other things. So the very high chances they'll secondary get infected. And varicella in adults can cause encephalitis, pneumonitis, and hepatitis. And varicella in HIV is progressive, hemorrhagic, and complicated usually. So varicella less than 12 years of age, we don't treat. We isolate the child and give symptomatic treatment. But more than 12 years of age, usually it's acyclovir or valacyclovir. So acyclovir dosage is 800 mg 5 times a day for 7 days, which usually people don't take because it's 5 times a dosage. It's not feasible. Like you can't take it like 5 times a day. So valacyclovir, it is 1 gram 3 times a day for 7 days. The problem with valacyclovir is just a little expensive, but it's still better than acyclovir because it's just 3 times a day. And prophylaxis, there is vaccine and immunoglobulin. So pre-exposure prophylaxis, there's vaccine, 2 doses, 3 months apart. Post-exposure prophylaxis, there is zoster immunoglobulin, which is given to neonates. And neonates exposed to varicella, immunocompromised, and exposed non-immune pregnant women. Okay, this is a spotter. This is, as you can see, it's only like 1 dermatome involved. So this is herpes zoster. So what is herpes zoster? It is reactivation of the latent virus in the dorsal root ganglion of the sensory nerve. So this is mostly seen in older age group. It's unilateral dermatomal grouped vesicles. So there are 3 stages: prehepatic, hepatic, and posthepatic neuralgia. So there are spinal or cranial nerve involvement. Usual cranial nerve is 5th nerve, that is trigeminal, or 7th nerve. So 5th nerve involvement, it commonly involves the ophthalmic division of the trigeminal nerve, causing herpes zoster ophthalmicus. The Hutchison sign. So if the tip of the nose, there are vesicles in the tip of the nose, means the 5th nerve is getting involved. That is herpes zoster ophthalmicus. And seventh nerve is the facial nerve, and that's called Ramsay-Hunt syndrome. And this is disseminated zoster, meaning more than 20 lesions outside the area of the primary and adjacent dermatome. This, next slide. Okay. When to suspect HIV in case of a zoster patient? Young patient, multidermatomal or cranial nerve involvement, hemorrhagic or disseminated, and varicose lesion, severe. So post-hepatic neuralgia is something which is pain persisting for more than 3 months after the rash heals. So there could be 3 types of pain: constant burning, intermittent stabbing pain, or combination of both. So for the treatment of this is either amitriptyline or carbamazepine. Sometimes gabapentin also is given. So treatment of zoster is same as varicella. It is valacyclovir 1 gram TID for 7 days, or acyclovir 800 mg 5 times a day. Okay, this is hand, foot, and mouth disease. So it's caused by Coxsackie virus, mostly seen in school-going children. So the main DD for this is erythema multiforme. But hand, foot, and mouth disease management is just symptomatic. Most importantly, hydration. We isolate the child and hydrate the child and give symptomatic management, and it vanishes in 7 to 10 days. Next, coming to warts. So there's different types of warts. This is Verruca vulgaris. This is Verruca plana. This is plain-topped verruca. Filiform warts, finger-like projection. And digitate, this is multiple finger-like projections with common base. Palmoplantar, these are like kind of more common ones which you see. These are mosaic warts. So how to differentiate between a wart and a corn? So a wart, there is always loss of skin markings like toes and fingers. That is called dermatoglyphic lines. Loss of skin markings, and this pain on horizontal pressure. Whereas in case of corn, the dermatoglyphic lines, that is the skin markings, are preserved, and there's pain on vertical pressure. And as we all know, corns are mostly seen in pressure-bearing areas, and wart can be either in pressure or non-pressure-bearing areas. And wart mostly have thrombosed vessels. So whenever you're like filing the wart or you're thinking, there will be bleeding. In case of corn, there's no thrombosed vessel. Next slide. This is a periungual wart. So these are genital warts, condyloma acuminata. So next slide. What are the complications of warts? So one, they can secondly get infected. In case of pregnancy, if there's proliferative growth of the wart, there could be obstruction of labor. And then it is known to cause laryngeal papillomas in child if the mother has a wart. Then malignant change, as we all know, Buschke-Lowenstein tumor. And since the same HPV virus is causing cervical intraepithelial neoplasia. So how do we treat? So usually the treatment for warts in like medical colleges and hospitals, they do cryo, but in rural settings, we don't have all that. So topically, we give salicylic acid, or there's something called wart solution, that is lactic acid and salicylic acid for local application. And you asked them to like file the wart slowly every day. And this solution is given for 3 weeks and like seen. So other things like chemical, like imiquimod and retinoids, everything can be done, but always consult a dermatologist before doing this. Next, how to differentiate between a drug rash and a viral rash. So both are macular rashes. So a drug rash usually is centripetal, and a viral rash will be cephalocaudal. So drug rash usually presents like 7 to 10 days after the drug intake, very itchy, whereas viral rash are non-itchy. And in case of drug rash, there is progression. So there is maculopapular to pustular to petechiae. And fever is low to moderate. But in case of viral rash, Fever is very high, and it depends on when the rash develops, and um, it's usually non-itchy. Then these are the special viral signs. Dengue, we see the islands of white in a sea of red. Then measles, Koplik spots, again the second molar. Then varicella, dewdrops on rose petals. Slapped cheek, we see in erythema infectiosum. Erythema infectiosum also will have very high grade fever with a slapped cheek. Then hand, foot, and mouth targetoid grayish lesions. Next are bacterial infections. The first picture is folliculitis. Then there's furuncle, carbuncle, and abscess. Then there is cellulitis and erysipelas. So there's impetigo and staphylococcal scalded skin syndrome. So mostly caused by So key questions in bacterial infection: one, if they're diabetic; two, if about HIV, history of HIV to be asked to rule out HIV. Then shaving practices, because some people develop recurrent folliculitis in the beard area, so that mostly is it'll be related to the shaving practices. Then what topicals they are applying, and what are the number of episodes they are having. So treatment we can give topical soframycin or mupirocin, fusidic acid. Next slide. So in case of cellulitis and SSS, we need to give them systemic drugs. Patient needs to be admitted and given systemic drugs. Recurrent episode of folliculitis, we usually give doxycycline, that is 100 mg OD, and carrier site eradication. Carrier site eradication is you give mupirocin ointment to apply on the nares, axilla, groin for around 2 weeks. Then below the inguinal ligament, if they are having, then gram-negative cover antibiotic to be added. And the major complication of all this is acute glomerular nephritis. So like after urine protein to be done, or like. Next is acne. This is a very common thing. Next slide. So comedones are the classical lesions for acne. So whenever patient comes with acne, we should look for hormonal, like if there's chin distribution, if the patient has hirsutism, menstrual irregularities, because PCOS acne is very common. Some drugs like anti-epileptics and steroids. Some syndromes can cause acne. Rosacea is it's not acne as such, but it's like this flushing and photosensitivity. Cosmetic, some creams and oils, topical steroids. Then some occupation of the patient, like some people having like a fast food or oil frying and violinist and all have acne, like, and habits like picking of pimples. So this history need to be asked. Next, treatment based on the stage of acne. So there are 4 stages of acne. First is comedone, next is papilla, pustula, nodular cystic. So in case of comedone acne, we give them like a topical retinoid, like you can give adapalene or BPO. So next, for papilla acne, we give topical retinoid and a topical antibiotic like clindamycin. Then for pustular acne, it's usually we can add a systemic antibiotic with it, that is doxycycline 100 mg OD. And for nodular cystic acne, its usual treatment is isotretinoin. So for this, usually don't start anyone on isotretinoin. Contraception is very important. So we should ask them properly, UPT to be done before starting. And at least 1 month after stopping, they shouldn't get pregnant. Next slide. Next, coming to fungal infections. The common fungal infection, this is tinea. So the first 2 are the classical tinea, that is annular, raised itchy lesions with central clearing. The second two pictures, it is like steroid modified tinea. So steroid modified, the inflammation will be low, so scaling will not be there, and the classical annular lesion won't be there. Next slide. Okay, so tinea, the patient usually comes with itching, and it's mostly in the groin. Tinea can be like anywhere, but mostly it's in the groin and in the buttocks. So the treatment for tinea, first is personal hygiene. So we'll ask the patient to like wash all clothes and iron it and then wear it, sun dry it and then wear it. Then for treatment of tinea, there's allylamine and azoles. So there's a thing. So whenever we are using a topical allylamine, we use a oral azole. So here, if you are giving terbinafine 250 mg OD for 4 weeks, we give a azole, that is ketoconazole cream, or ketoconazole for 4 weeks. So whenever we are asking them to apply the cream, we always tell them, because tinea, we know the activity is more in the periphery, the active in the periphery. So we tell them to apply 1 centimeter around the lesion whenever they apply. And if not terbinafine, we can also give itraconazole 100 mg BD for 4 weeks. So this is off-label, which is not there in any guidelines, but still, like many people do it. Fluconazole 150 mg to 200 mg twice a week. You give it for like 4 weeks, along with a topical antifungal. This is pityriasis versicolor. It is again, next slide. It's a fungal infection. So for the treatment of pityriasis versicolor, it is fluconazole 400 mg stat, or you can give topical ketoconazole 2% cream, or topical ketoconazole shampoo. Next. Next is candidiasis, oral candidiasis. So whenever
Ancia, it is 30 minutes, so we
okay,
have 5 more minutes.
Okay, fine. Next. So oral candidiasis treatment, fluconazole 100 mg OD for 7 to 10 days, and you give cotrimazole paint. Vulvovaginal candidiasis, fluconazole 150 mg stat. Next. Okay, this lice is very common in rural areas, and I mean, it's mostly in school-going girls. Next slide. So for lice, the treatment, so any teenage girl comes with retroauricular lymph nodes or multiple pustules on the scalp, you have to rule out lice. And treatment for this lice is permethrin 1% once a week for 4 weeks. And we have to instruct them clearly to remove all the nits. Next. Okay, scabies is another very important common condition which they come. So this usually patients come with itching. It usually involves the circle of Hebra, which is the interweb spaces, the wrists, axilla, around the breasts, umbilicus, and the groin. So classical is the nocturnal itching, and the family history is present. They come with like all people in the family have the same itching. Treatment for this is 5% permethrin cream, and the most important is you treat the whole family together at once with 5% permethrin cream. So the contact time is 8 hours. So you will ask them to have a early dinner and apply. For children, apply it on the face, but for adults, it's generally below the neck. You apply completely throughout the body, leave it for 8 hours, and then wash. Next. Okay.
Just one thing for permethrin application, below 1 year of age, you'll apply on the face and scalp as well. Above 1 year of age, you apply from neck down. And if the mother is breastfeeding, she'll have to wash it off just before feeding and reapply it.
Thank you so much, Ancia.
Okay.
I request Mihika if she has to add anything in the whole content, or otherwise then we can take questions which are in the chat box.
We can take the questions, then I'll sum up if anything.
Okay. The first question is by Dr. Milind. He wants to ask, is there a role of topical acyclovir for treating herpes?
See, there are no official guidelines that recommend topical acyclovir. The reason being that the source of the infection is always in the nerve. So applying it topically, it never reaches the ganglions where the nerves are, where the virus stays. So it's always preferable to give oral acyclovir. Topically, if it's in the oral area, we used to normally give Vaseline. If it's secondarily infected, you can actually give a topical antiseptic cream, something like soframycin or fusidic acid. But we don't give topical acyclovir.
Next question is regarding hand, foot, and mouth disease. It was explained that it happens in the children and in the adults. So my question was, is it harmful in adults? We had a case where a parent and a child both were infected at the same time. So what is to be told to the patient in this case?
So hand, foot, and mouth tends to be very contagious in children. Like you'll have outbreaks in schools and play groups and play school and daycare centers. It can affect adults. It's not that it doesn't affect adults, but most people have already developed immunity to it. In children, our main concern is that you can't force a child to eat. So dehydration is of concern in children. Sometimes people need to admit the child for IV fluids because they're not taking orally. Adults, that's not an issue, but adults, whenever they get viral infections, tend to do badly systemically. So they may have high fever, they'll be a little bit more toxic, and some adults don't tolerate pain well, so they need stronger pain relief medication. Quarantine is important for hand, foot, and mouth disease. Till the lesions dry up, you have to keep that kid at home, otherwise it will keep spreading.
Thank you. Fala has questioned, what is the percentage of salicylic acid for warts?
So if you're making the ointment, you're compounding the ointment, we usually give 5% salicylic acid. But over the counter, what you get is 6%. The most commonly available solution is actually a combination of salicylic and lactic acid. Trade name is Salactin. I don't think anyone else manufactures that combination also. So Salactin is what they use. So you have to apply Vaseline around the lesion and paint it. Most of these lesions drop off in 6 weeks, regardless what you do, whether you cryo it, cautery it, or if you punch it out, it takes that long to heal. So anticipate 6 weeks treatment. And a add-on that you can do in Warts treatment is to add zinc supplementation.
Is it oral zinc?
Oral zinc.
Okay. Asha has questioned, what is the treatment duration for acne?
So the thing about acne is, as long as you're in that teenage to early adult age group, you can get 1 or 2 pimples. You have to explain to patients that this is normal. There's not a single human being who never gets pimples. Someone gets a pimple at some point of time. Severe acne, we usually give oral medications for around 3 months. And then we put them on maintenance therapy. So if you're starting things like doxycycline, isotretinoin, you have to tell them not to stop their treatment before 3 months. After 1 month, they'll feel like their skin is fully clear. They'll stop the doxycycline. They'll have a flare, and then it will start all over again. So you have to counsel your patients that their whole acne treatment, they need to be prepared for at least 6 months of it till, everything goes into proper remission. And then after that, they'll need things for the one-off flare which comes. And if they have things like PCOS, or they have used a topical steroid on their face, it's pretty common for people in India to, for some reason, apply Betnovate on their face in the hope of making themselves fair. So they have topical steroid-induced acne. Those kind of cases you might end up treating for 1 to 2 years. If you want acne to subside, you have to treat underlying conditions. So you have to treat polycystic ovarian disease. You have to modify their diet. So milk and milk products are something that we now recommend to avoid in patients with acne. You have to make sure that they are not insulin resistant. So fruits, vegetables, low glycemic foods, less of refined foods. Avoid bakery products are things that we do tell our patients if we want to produce a sustained remission in acne.
Dr. Pranita has asked, what is the treatment of recurrence of dandruff and itchy scalp?
So the thing that we colloquially refer to as dandruff can be one of two different entities. One of which is called seborrheic dermatitis and the other is known as psoriasis. So you can have psoriasis exclusively on the scalp without having body lesions as well. So you have to differentiate whether it's seborrheic dermatitis or whether it's scalp psoriasis. Scalp psoriasis tends to be dry. You might actually see a small psoriatic plaques on the scalp. When you dust it, it's that same silvery scale which you see on psoriatic plaques on the scalp falls away. Seborrheic dermatitis tends to be erythematous, greasy, yellowish scales which stick to the scalp. So that's what people commonly call dandruff. So when we treat dandruff, we usually give people a ketoconazole shampoo. Nowadays, the combinations come with zinc parathion. You tell them to use it at least 3 times a week initially. And we give this for around a month to 6 weeks. Once the dandruff and the inflammation has subsided, we ask them to use it approximately once in 2 weeks or once a month. That's how we treat the dandruff. And if it's severe, the inflammation, we can use a topical steroid. When it comes to treating psoriasis, we use a coal tar-based shampoo along with the coconut oil.
Hello, sorry for the glitch.
Yeah, no problem.
Yeah, we'll take Samir's question. How long a patient can continue fluconazole and terbinafine for the treatment of tinea? Persistence of all signs of tinea even after 28 days of compliance to the treatment.
So the problem that we are facing nowadays is drug resistance in tinea. So even though we are giving treatment for 4 to 8 weeks, we are not seeing improvement. This is the point of time which you are invariably going to have to switch over to itraconazole. Before you do that, if you've given patients terbinafine for a long duration, you ask them for a creatinine and a liver function test. This test has to be done because they are hepatotoxic drugs. Once that is done, there is one thing about itraconazole which is generally not seen in other drugs is you have to make sure that the quality of itraconazole you're using is very good and you have to dose the patient properly. So we usually give 100 mg BD of itraconazole. It is an expensive drug, but unfortunately, this is a result of using topical steroid combinations very widely in a lot of patients. So you have to switch over to itraconazole. When you're using itraconazole systemically, you have to give terbinafine or an allylamine topically. Do not use the same group of drugs. This is what leads to resistance. So people give fluconazole orally and they give ketoconazole topically. Fluconazole is not an ideal drug, first and foremost, to treat tinea. It is one of the causes of why we have so much drug resistance. And another thing that you need to look at is where all the tinea is present. So if they have nail tinea involvement and you've treated the skin and you've not treated the nail, we give itraconazole pulse in nail in onychomycosis. If you've not treated the nail, it's going to come back.
Ambika has asked, can vitamin D deficiency cause hypopigmented spots in pediatric age group?
So vitamin D deficiency does not per se cause D or B does not cause hypopigmented spots in children. It will depend on what your hypopigmented spots are. So what we commonly see on the face, which we call pityriasis alba, which are dry, scaly patches on the cheeks, are actually precursors to atopic dermatitis. They're not usually nutrition related, even though a lot of people might tell you that. The treatment for that is we used tacrolimus, pimecrolimus, and moisturizers, and it usually resolves with that. However, in India, in general, people are vitamin D deficient. So it's generally a good idea to correct that. B12 can actually cause hyperpigmentation rather than hypopigmentation.
Thank you, Mihika. These were the questions. Still, anyone can add the questions in the chat box. I request Mihika, if she has to add anything to the presentation till now, please do so.
So it's important, like if you're discussing with a dermatologist, to give the complete history. So very often when people discuss with us, we just get a random photo with no context. and we don't even know which part of the body it is, because like you all have taken like a macro shot of only that lesion. So there are a lot of hints in the occupation, the age, the duration of symptoms, associated symptoms, whether they have fever or not, that you need to pay attention to when you send your details to a dermatologist, because the same condition, the extent of treatment that I plan to give will depend on what you tell me. And if you don't tell me these things, I'm going to assume that they're not there, and it might affect the treatment. And if you're referring a patient to a dermatologist or a higher center, for something that is chronic, it's best to send your patient with some baseline investigation. So you discuss your case before you send your patients always with a referral letter, which details all the kinds of treatment that they've taken. So very often patients will tell us they've not taken a treatment, but you have to remember that it may not just be a treatment, like it might be some kind of a home remedy or anything, because we have a lot of contaminants now, especially heavy metals. So treatment history, including complementary and alternative medicine, has to be elicited from your patient. So at least we know if something is triggering it. So you have to tell me your routine medications also, like your diabetes medication, your hypertensive medications. These are known to cause dermatological conditions. And you have to tell me what alternative medicines have been taken and what the response to those medications have been, if they have been used to treat the thing. So if the patient has used steroids, did it improve with that? If the patient has been given terbinafine for the fungal infection, did it improve with terbinafine or it remained the same? Because if it improved partially, you might just have to give the treatment for a longer term. If it didn't improve at all, that means there's resistance. And that's it. And yeah, don't use topical steroid combination creams. Please don't do that. It causes resistance. Fungal resistance is not something that rural people in India can afford to treat.
Thank you so much, Ancia and Mihika. This was the starting of the dermatology series that we are planning to continue in the CLS. I request Mihika, she has got a Google form for people who are trying to refer the dermat patients to her. If she can share it in the learning participants group after the session. Okay, we have another question here from Dr. Milind. How to manage recurrent urticaria? Patients usually feel good on taking second generation antihistaminic drug, but after some days, he can come back with the symptoms. Mihika, would you like to take it?
Yeah, so we'll be dealing with allergies in depth in the next session. If you have a patient currently, keep them on the second generation antihistamines. So the thing about chronic urticaria, which has no known triggers, it tends to be autoimmune, as in it's occurring because the patient is producing autoantibodies. Or it can be auto-inflammatory. So in those cases, usually you have to keep them on antihistamines. Some of them are on antihistamines for around 2 or 3 years also. Antihistamines are relatively safe drugs, so we are not worried about side effects. Your problem only arises if your patient's not responding to antihistamines and you're looking at maybe cyclosporin or steroids, or the patient is steroid dependent, then it's a problem. It's safe to keep your patient on an antihistamine, and usually their requirement starts dropping after 6 to 8 months. So you might be having them on 2 antihistamines a day initially, then 1 antihistamine, then they might be able to go 48 to 72 hours, maybe once a week. Then they might get an episode once in 3 months. So your patient will improve, but you have to counsel them to take the antihistamines the way we counsel people to take diabetes or hypertensive medication, like every day without fail at the same time.
Thank you so much, Mihika.
You're welcome.
If you can share the Google form in the end, in the learning participants group.
I'll put it in the group, yeah.
Yeah, thank you so much. So after this, like any one of us want to refer the patient or take consultation from Mihika, that Google form is a really good option where we have to put all the history examination pointers and then share with her. If anyone has any questions, still we can take it. Or any opinion or any comment, anything if anyone wants, please unmute and speak. Okay, so thank you everyone for joining. Thank you the presenter, Dr. Ancia, and thank you the advisor, Dr. Mihika. We will look forward to the next session. Please post your feedback in the group, and we will share the Google form of the dermatology consultation soon. Thank you so much.